Yes. Right. So Caitlin, you're the first one on my screen.
All right, hello everyone. I'm Caitlin Hebb, as Deanna mentioned. I am also, my upstairs neighbors are doing a little bit of construction, so you might hear some in the background, just putting you out. But yeah, so I am the clinical operations manager for MedRhythms. I am a neurologic music therapist fellow. I primarily work at Spalding Rehab in Charlestown. They have a few locations, and I'm at the Charlestown, which is their inpatient rehab facility. In addition to that, I also provide telehealth and some in homes as well. So that's me. I'll pass it to Delaney.
Thanks, Caitlin. I'm Delaney. I also work at MedRhythms with Caitlin. I am a neurologic music therapy fellow, and that's the first time I've introduced myself as that, so very will be excited about that. I work at Spalding Cape Cod, inpatient, and I do a lot of teletherapy work and a few in homes.
And my name is Hannah Cox, and I am a speech language pathologist, and I work at Spalding Rehab Hospital in Charlestown. I work on the brain injury unit, and I have been there about 5 years now.
Awesome. And then my name is Diana Cortez. I am NER-AMTAS president, and I just finished my internship a week ago, actually. and and yes, and my internship site was a neurologic music therapy based site at Spalding as well. So yeah, I'm just gonna go ahead and start asking the first couple of questions. So first, I would love to hear sort of like how do you explain people what is neurologic music therapy? From your neurologic music therapy's perspective, but also Hannah, when you're talking about it, I would love to hear how you explain it to people as well. So why don't we start with you, actually, Hannah?
Sure. So usually when I'm explaining it to patients or their families, I try to talk about it in terms of just keeping it as simple as I can, only because I feel like the buy-in sometimes for families is usually there, but sometimes if they're thinking like, oh, it's taking away from our speech therapy time, or oh, my family member doesn't like music, or sometimes families come up with the weirdest explanations for why they might not be interested in trying something. So I usually just talk about it in terms of, we're gonna try to incorporate music, and I talk about it in terms of, right hemisphere controlling rate and rhythm, which can help with left hemisphere activation for language, and how the brain works together to produce language. And usually at that point, they're like, oh, great. If we can use the preserved parts of their brain specifically for language impairments, then that's great. And if it's for cognitive reasons like attention or memory, I find those are the cases where I tend to have to explain it a little bit more, since it's like, well, the right side of their brain is the impaired side. How do we, it's like, well, neuroplasticity, reactivation, neural growth, and then I get a little sciencey, and try to explain it to them that way. But then by that point, I feel like they're like, oh, we're willing to try something because you're recommending it and you think it's going to be beneficial for my loved one.
Yeah, and I can jump in just kind of giving when we typically explain it to individuals who ask us, we've reached out to music therapy services before. We're looking specifically, for NMT, and I think for us, it's really more about kind of the process, right, of understanding music and the brain and how it affects non-musical functions, and then designing really targeted interventions to address those non-musical goals. And that doesn't mean that it isn't, emotional in nature, right? Music has saliency, and we definitely harness that within our practice, but it's really more about assessing them, their baseline, and that's at where, speech pathologists come into that co-treatment process, is really being able to give us what is the patient's baseline functioning and how can we truly use music to harness and and enhance that process. So I think it's really about that, like assessing their baseline function, what we call the transformational design model, which is, you know, assessment, non-musical activity to a musical task into the carryover piece, right? We're looking for them to be able to really have more of a functional carryover than a musical carryover. So that's kind of how I would describe it as well.
I mean, same thing, just to piggyback off of Caitlin. I've been surprised how many people, whether it's the patient themselves, the client, or the family members, have heard of music therapy, but to the extent that they've heard of neurologic music therapy and what that will look like for themselves or their loved ones. And you know, as Hannah said, getting sciency, I think that's where we grab people, talking about like, well, we're based in a neuroscience model at this point. We're looking at how your brain is changing when it's engaging in the music that itself. And I've found to really grab people with the music is my tool here, um, so to speak, as yes, you're going to work on your goals, but we're using music as our tool to get there.
Mm-hmm.
Yeah, and I'm curious also. So you've, you know, all of you are very experienced and have had experience with NMT and co-training with SLP for some time now. But I would love to know, like, what was, so like your first encounter to NMT, and what was the thing that made you stay with it? Like, what's the thing that, as used in the video, made you stay with it, that could also be used as, so like, a selling point for when you're talking to other people about it?
So I think as a speech therapist, you know, in graduate school programs, you learn all about melodic intonation therapy as a treatment technique, right? And I think my first time ever co-treating with NMTs was probably in my first year as a licensed clinician, and it was probably a patient with aphasia, and we were probably trying MIT with them, and I remember thinking like, okay, I know the theoretical knowledge of how to do it, why it works, but how do I actually get somebody to do it? And then I think I probably worked with Brian Harris because he was still working at Spalding at that time. And he kind of led the way and showed me how to do it. And I was like, oh, that's really awesome that you also know the theoretical knowledge and can apply it in this case, and then can teach me how it actually looks in real time. And then from there, just going and being like, oh, wait, this could be used for my patients who have a less neglect. This could be used for my patients who have really bad memory and orientation. And it just kind of exploded. And I realized, wow, you guys are using the same theoretical knowledge and background that I have, but you're incorporating music to make it more salient for people. When it's not just hearing something over and over again. Sometimes if you pair with a melody, you know, there was just so much that I was like, oh, this coincides with everything I'm doing too. Why wouldn't I use that as a therapy tool and technique? So I think ever since then, it's been at least like once a month I've been emailing to get co-treats for NMT.
Yeah, and I think for me it was really, you know, just how I like stayed in NMT. You know, I actually, in my journey, was probably not going to pursue music therapy post graduation, and I just so happened ended up at Spalding. It was the first time they were offering the practicum site as I'm also a Berkeley alumni. I don't know if you all know that, but so I you know had first encountered it with Brian Harris at Spalding Cambridge. And I think for me it was because I actually saw where the functional piece, that's super huge, to be able to say to my patients that I can improve their lives in X, Y, and Z ways, and they also are experiencing that. And so I think that for me, that was kind of why I chose NMT. I love being able to explain why music works and from a neuro level, and I love being able to back it up in research and literature that's out there. And then also the co-treatment experience with speech pathologists, but the other disciplines that we work with at Spalding, it's so rich. And I think like we are, it's really special in the way that it's not just, you know, music therapy and SLP, but it's, you know, speech therapists and OTs and PTs that are all working together for that one patient. And there's a ton of overlap. It's constantly overlapping in our work. And that's how we make it the best possible care. That's right. Like how you'll hear healthcare systems all around say the highest quality of care. And I think at Spalding, we're truly exhibiting that through the knowledge sharing and really making sure that everyone's goals are on the same page, but we're all using different mechanisms to address it. So.
As a fairly new clinician myself, almost 2 years here in the field of NMT, what really grasped me into when I was a music therapy student was my brain and behavior course. That was, a required course. And I took it and realized there's so many things here that transfer. There's so much overlap here. And it was before I even took any of my really big core music therapy courses. So to get that idea right off the bat was huge. And I think that helps with how Deanna had said, well, how does your experience, why did you stay here, help with advocating for what you're doing for clients? I mean, it was huge to see like there is overlap between music and the brain there's overlap between music and these non-musical things that we are targeting in the brain. So keeping in the field of NMT, same thing along the lines of what Caitlin is doing, to be able to see it every day in a functional way with functional outcomes, and to see, my clients who are weekly coming back. And I'm sure Deanna will get us into questions about assessments, but like to see the data of clients' progress and to know that it is based off of what we are doing in the fields of research and what we are doing, with our knowledge of the background of neuroscience. This is the why that we are seeing this every week.
Yeah, and thank you actually, Delaney, for bringing the assessments, because we're definitely going there. I feel it's a common question that I encounter in like other presentations, that there are other clinicians that are pushing music therapies like to assess your clients and blah blah blah. But sometimes getting access to those assessments, standardized assessments, it's hard, and also some of them require special training. So I feel like that's a huge obstacle for many music therapies. So like in concept of like, oh, I don't have the training, therefore I cannot apply this assessment. And I think sometimes it's also good to have in mind that it's not for the, as a clinicians, for example, at MedRhythms and at Spalding, in my like intern experience, I didn't use assessments to diagnose, right? Because the diagnosis was already there by, the speech pathologists or all the physicians and everything else. And it was more of like me understanding the baseline of the patient and where we could get off, and also to just keep using that as backup of the actual progress of our work. And I'm curious, Hannah, have you ever, like, what, as an SLP, so like an outside person of NMT who, you've had your trainings for applying assessments, I would love to hear your perspective on that specific topic about assessments and us using it for our clients and patients.
Like NMTs using speech assessments?
Yeah, speech assessments, and from something like aphasia, like a DCP aphasia, or something a little bit more cognitive, like the MOCA. Yeah, I would love to hear your opinion on that.
Yeah, I mean, I think at least where I work, I feel like the use of assessments in our field of inpatient rehab is probably not quite as common as it is in like the home settings or as an outpatient. Because if Caitlin is coming to co-treat with me, she's not necessarily going to do an aphasia assessment because I've already done the aphasia assessment, or I've already established that they have severe cognitive impairments based on their scores. And I do think that that issue of NMTs using assessments to like assess, I'm not gonna necessarily say like diagnose those impairments. I think that's probably where the issue is in the field of speech therapy with some speech therapists not necessarily loving NMT's involvement, because I think those SLPs probably think that NMTs are stepping on our toes, when really, I think if you know how to give an assessment and you know how to interpret the information, I don't know that you have to go to graduate school to read a manual to figure out what a score means. I think the way that a speech therapist gets involved is then in the treatment planning of knowing what that means for this particular individual and how do I get them from this point to move forward. So I think it's really interesting that that's an issue apparently in the field, because I don't really see it as wrong. I think the issue would be if you had information from an assessment that you gave and you didn't know what it meant, and then you just went ahead anyway and did something, right? So I think it's knowing if you're going to give an assessment, okay, and you can read the instructions and okay, I show them this object, I ask them to name it, they can't name it, I give them this cue, right? Everything is pretty much written down. There's not a lot of assessments where you have to interpret how to give the actual test. But then if you get results and you're like, oh yeah, I don't really know what that means, I'm just going to do this, then that's a problem. But if you can say, okay, I don't know what this means, let me go reach out to my resources and ask them what that means, I think that's absolutely fine. I think the issue is these assessments are expensive. And, to be making sure you're giving them the right way, to have the right assessment forms, the tools, all of that can probably be a barrier to access in the community for NMTs that are maybe having their own private practice or just seeing a few clients at a time. You're not necessarily going to want to spend hundreds of dollars on these assessment tools that you might not need to use if you have access to a speech therapist or an OT or a PT that's already doing those assessments anyway. So that's kind of my 2 cents.
And I think that's the beauty of an interdisciplinary approach. As someone who does a lot of teletherapy, what's considered the outpatient, I find that a lot of clients and caregivers are very open to you reaching out to their other therapists or sharing that information with, giving that consent. So that way, if you are at that point, like Hannah said, where you're at that situation where you don't know if someone already did that assessment that you're struggling with, you can try to reach out if they're in other therapies. But what's also good to know is a lot of assessments are available for free on the internet as well, and pretty straightforward to use, as Hannah said, and really necessary for us at any point of the treatment process, inpatient to outpatient level, as they help us direct our therapy and decide if it's music as therapy versus music in therapy. So just my 2 cents there.
Yeah, and I think the main difference here is knowing what we're using it for, right? We might use a scale within a diagnostic assessment, but we're using it to test function. We're not using it to diagnose. So I think that there's, diagnostic assessments and there are functional assessments. And I would communicate that with, if I was doing a teletherapy session and I reached out to a speech pathologist and said, hey, I'm doing this only to really get a true baseline so that I can reassess at a later date of whether my intervention is working or not. So as long as you use the right language and you open that communication and you set it up the right way, then they're going to be much more approachable and understanding of why we're using those assessments, outside of just saying, hey, I used this and they have global aphasia, right? You wouldn't approach a speech pathologist in that way. That would be very silly. So just knowing how to communicate the right way, I think, is super important.
And to go off of like that communication, say, what would be your advice, also from an NMT and an SLP point of view, for people who sort of like don't have the opportunity to work at a hospital that has like such a pushing culture of collaboration between disciplines, and they can be either private practice or they are actually in a hospital, but it's just not something that's part of the work there. What would be your advice for like initiating or growing a relationship with an SLP to, so like having a potential co-treatment at some point, from the point of view of someone who's never done, like, so like taking that first step?
Mhm. That is a really good point and a really good question. And I think, there's, like I said earlier, there's definitely apparently a culture of SLPs being a little hurt that NMTs are trying to step into the field, right? So I think if you're in a setting or dealing with, not knowing who to contact, who to get in touch with, definitely situation specific and setting specific, but I think just reaching out either via email or if you happen to see someone in person, and just saying, hey, this is the situation that I'm dealing with. I'd love to have your input, and I'd love to see if we could work together on something for this particular individual, and I would love your guidance, and I'd love to work together to share my knowledge, and broaching it as a collaborative effort. And if they're resistant to it, maybe just saying, okay, well, I'd love to share some of the research that I've found that helps me make my decisions, and so that they know that it's not just music as therapy, as Delaney was saying, but music in the therapy. I think that would be helpful, because there are probably some speech therapists that are a little more concrete in their thinking and very old school, one might say, and how they approach and treat patients. And they might not be as open because they're not exposed to the research, because they haven't had to really approach the research in a while to see what the newest things are in the field. And so bringing your knowledge to the table and kind of sharing that I'm not just here playing music for this patient, this is what I'm doing to help their brain, and you're doing, you also want that to be better. So this is how we could do this together. But I think definitely just reaching out, email, if you can get them in person, even better. But not being afraid to ask for that, or talk to if there's like a coordinator or a supervisor, going to them to say, hey, I'd love to do this with the department. Again, if it's like in a specific setting. And then if you, like Delaney was saying, if you have a patient or a client that's at home, asking the family if they would feel comfortable with you reaching out and getting the contact information for the other clinicians, and just starting to collaborate and co-treat that way. Because again, a lot of times I don't always know that everyone knows who's involved in the care of that particular individual. We see it as like, this is my role sometimes, especially if you're not being surrounded by the other people who are also helping to care for this individual. So in those settings, I can imagine it would be really difficult because you don't really know who that person is to go to. So just seeing if you could, if it's like a family member, or if it's again at a particular setting, like an outpatient clinic or acute hospital, something like that, in going to the department director and asking them for their guidance on how to get involved. And it probably will take a little bit of time. I know I can't say I know, but the NMT at Spalding, at least, I know was a very big development project. And I think is something that I'm so grateful to have, but I know that it can be tricky scheduling wise, and there's other things that come up that make it difficult to get them consistently involved in patient care. But that's a different conversation.
Just to share experience from what Hannah was saying, I find a lot of the times going to the speech pathologist and sharing what your session was like, your one-to-one session, you and just the patient, and saying, this is what I did, this was why I did this, and this was the outcome. I find a lot of times it got the speech therapist to at least want to observe. So like you have step one there, if they're like on that I'm not sure kind of area, that gray area. But then also saying, here's what I did and here's what I saw. But if you were there, if we had that collaboration, I think I'd be able to, or you'd be able to help me, or we'd be able to help each other for this patient. at the end of the day, I think when you have the approach of like, it's not about me, it's not about you, it's about the patient, it's the best way to get that collaboration and form that relationship. In terms of teletherapy, I've invited a speech therapist to observe a session, and that has opened up a conversation. It's a little bit harder, obviously, to collaborate on teletherapy or to do a co-treat on teletherapy, but it has allowed us to send emails to collaborate about that patient or that client, and to share our treatment plans and to make sure we have the same goals and we're going in the same direction.
And let's not forget that, like, it's not just speech pathologists who are defensive here. I think it's also music therapists in the situation. And so when you are approaching another professional, it's really important to not have that defensiveness, right? Like if you forget that it's about you and it's about the patient and you're going in with that intent, I really like that Delaney said that it's not about you, it's not about me, it's really about the patient. And I think if you go in with that mindset, you're going to get a completely different outcome than if you go trying to show off how much you know and how much, music is helping this person. It's really not about that. I also think that you can't take away the fact that, there's this kind of, you have to really hustle as a music therapist to build relationships even beyond the clinical stuff, right? Like I also just happen to really like Hannah, but I spend some time getting to know her as a person, and I think that's really important because it opens the line of communications. Her and I communicate really well when it comes to patients, or at least Hannah, I don't know if you want to.
I was just saying that the other day to my student. I was like, Caitlin's the easiest to work with because I feel like we just know what the other person is thinking, and when we're in the session together, I feel like we just jump off of each other, what we're saying, what we're doing, cueing, and it just flows so well. But you're right. I feel like we did take the time to get to know each other and build a relationship so that when we're in a patient's room, we know enough about each other to know our communication styles to help this person and have it not be about us, but have it be about them.
Yeah, exactly. So I would say, like, don't skip the step of building a relationship with someone first before you say, like, here's everything I could do for this patient. And you might only have that amount of time, and that's fine in a sense, but as long as you come with the right intentions, it's going to be a lot more transparent than you being, defensive as well.
And I love that you both brought up the part of like that co-leading dynamics, because I remember that that was one of my first like questions coming as an intern, and when I was doing my first observation, I was like, how do they know like who's like taking the decisions? And I'm like, is there like a secret communication that they do like right before the session and I just haven't witnessed it? Um, um, so just in general, as co-treatment, like regardless if it's, with NMT or OT or whatever, in your co-treatment experiences, um, maybe what are a couple of the do's and don'ts for establishing a functional and also like enjoyable co-treating session and dynamics with your peers?
I feel like from my side of things, whether it's co-treating with an NMT or just co-treating with my OT or PT partners, really establishing right off the bat, okay, today I want to work on this, or my role is going to be this. And then, like, let's say it's Caitlin, for example, right? She will then say, okay, so are we thinking we want to start with this? And then she puts her expertise of okay, let's start with a warm-up song, then we'll jump to like phrase completions, and then at the end we can do some MIT. And I'm like, yes, exactly, because I wanted to work on their automatic speech, I wanted to try MIT for these phrases. But so I feel like I tend to just be like, this is my goal, this is what I want to do, this is how I'm going to structure the session, and then you give me your expertise on what you're doing. Or if it's PT and OT, I'll say, okay, I'm going to be focusing on cueing them to remember to push up from their wheelchair. So then the PT knows they don't have to do that, because that's my role in this session, is I'm going to be, wait, what do you have to do before you stand up? And that way it's not 7 people talking at once either. Because that can be really overwhelming for people when there's extra bodies in a room. knowing your role so that you're not talking on top of each other or saying the same thing over and over again. And just knowing, just really establishing your role right up front, I think is the most helpful thing.
Yeah, and going into a session, it's always helpful if this is the first time you're treating them. So obviously do your chart reviews, but as you go into that session and you don't know if you haven't had time to connect, like if Hannah and I haven't connected before the session starts, then usually what I'll say is like, do you mind just showing me what you're doing already in sessions? And then you can do that kind of like musical transformation as you're seeing what the other clinician is working on. So just show me what you're doing, and then it's a collaboration by being like, okay, I see you're doing this automatic, so we could try it in this way with the musical piece, right? It could be super effective in this way. And really kind of approaching it in that asking them, right? Like always ask your other person in the room, like what they think about what you're clinically, implementing or what you're clinically thinking as well. And I think questions are really like the most approachable way when you're thinking about collaboration. It's really good to just say, this is what I'm thinking. What do you think? And approaching it from that, because then it's just naturally collaborative, right? Like you're asking them a question, so you're going to have to collaborate and they'll respond. Yeah.
I think just with what Caitlin said, that's when you have that new collaboration, that new relationship building. Yes, here I am going back on the like, it's not about me, it's not about you. But when it's you and that new OT, PT, speech pathologist that's never collaborated with you, never collaborated with NMT, I think it's really important to really focus on that relationship in the moment with those questions. You are building that rapport with them. I know we talk a lot about like building the rapport with the client, but building the rapport, as Hannah and Caitlin talked about, building that relationship with you. So asking the questions and saying what Caitlin said, I'm seeing this, what do you think about that? And in turn, I've started to see it coming back to me from those new coach treats. Well, I'm seeing, do you think, yes, I have, forward. And then, of course, when you finish the session, you don't just leave, right? You want to go back, find that person you collaborated with, and continue the conversation. If you, of course, can always do that follow-up.
Yes, totally. I've definitely, I think it's definitely a learning curve, as you know, when I first approached it, and specifically because, so like from my point of view, SLPs and OTs and PTs are so like ancient established disciplines, and we're so like kind of like the new guy. So in my way, it's like, oh, I mean, they're so like they're they have the sort of like right of floor. So like they got there first, so I was like, I don't know how much, so like I thought authority I could put in this dynamic. So I think all of these advices, it's great, and also just having, I think at the one of my takeaways, for example, of what Caitlin said, is the just making sure that you are coming up from a non-confrontational space, but also not downplaying also your expertise. Not because we haven't been as long as they have doesn't mean that we're not good at you know our fields, and the whole point of collaborating is to give the best care for the patient, because each of us, even if it's on the same discipline, like two SLPs working together or two NMTs working together, each individual have their own clinical knowledge that they could add, for sure. And
Can I add to that too? I think it's important like, you know, the field of NMT, the point, or, you know, from the academy is that we would like NM to be a household name. Like, we would like it to be PT, OT, speech, NMT. Every person that comes to Spalding is getting an NMT referral. And I think that that is, the only way for us to do that as a field is to know the value of the work that we're providing, and further, I think, kind of showing that value, right, to not only our the other disciplines, but like insurance companies, and showing that like we're truly making functional change. Because I think that if you can't measure it and you can't show people the work that you're doing, and if you say that you're doing, you know, oh, I'm working on all of these things at once with music, you really muddy the water, right? You don't actually know when you walk in. People are confused about what you actually do. So having a very narrowed scope of your practice and a specialty, I think, is super important as you're a young clinician. And maybe Delaney, you can speak to this, but like being a young clinician and walking into a field of NMT that is, we're over here in speech world, gait training, you know, cognition, there's a lot to learn. And so I think really, you know, taking your time, gaining the knowledge, honing in on your specialty, will really help establish what it is you work on, and other people will know clearly what it is that you do.
Yeah, Caitlin said it all. As a new clinician who is, you know, in a setting where I'm still every day finding that I need to advocate some way, or like teach someone something about what I do. Everything Caitlin said, but also like knowing who I am and my value is where I think I went wrong at first. And like, you're obviously, as a new clinician, there's going to be something. So if you can know what you're doing and be, here's that fun word, confident in everything that you say and do, I think it's going to look a lot easier than it seems to approach somebody that, you know, like Deanna said, is already there, that the popular kid in school. You know, it makes me think of like those movies
The
where
popular kid, Hannah.
Right. Well, it makes me think of those movies where like the kid moves and they're the new kid in the school. It's like,
Yeah.
don't be the new kid. Like, you know, come back to you don't know it all, but like you're the expert in your field. You're the expert in NMT. So share with them what you know. Know that you have value in what their patients, and here we come back to, at the end of the day, it's all about the best experience for them.
And I can just say too, as someone in the established field, right? There's still so much that I don't know, and there's so much about your profession that I still learn on a daily basis when I co-treat with an NMT. So that confidence piece, I think, really is important, because if you come in the room and are like, oh, I don't know, what do you want to do? I feel like, well, I don't know, what were you gonna do? Like, did you have a plan? Did you have an idea? I want to hear your ideas. I genuinely do. And there have been so many times where I've called, you know, NMTs and on a complicated case because I was kind of at a loss for what else to do. And I didn't really know what was going on. So knowing that the people you're working with are also probably still having some questions about things, and they don't know everything either. So that confidence piece, I think, is really important too.
So Hannah, you just said, so like one of your so like goes when you're working with a complicated patient, usually that's a great way for you to say like, oh, I think we need like a different perspective, a different approach to this. But what other so like criteria do you look for in patients to determine if they're appropriate for an NMT and SLP co-treatment session, and for both is perspective in disciplines?
Yeah, I mean, I think everybody is appropriate, like Caitlin said, for an NMT consult. I really do. And I was even trying to think, when she was talking about like some of my higher level patients, like what they have, like maybe some trace to mild cognitive issues or working on executive functioning stuff, return to work. And I'm kind of like, why don't I consult NMT on those people? Like, I have no reason not to. I think in my head, it's just like, oh, most of the time I feel like our co-treats are either really, really low level cog, and we're working on arousal, alertness, initiation, attention, or aphasia, where I want to work on verbal expression, auditory comprehension, right? So, you do kind of after a while pigeonhole yourself a little bit into like the typical patient that you would consult another discipline on. But I think generally speaking, as long as they're awake, as long as their eyes are open, and if they have, anybody, now that I think about it, it's like, I don't know a single person, like maybe a patient with disorders of consciousness who is in a vegetative state, you would really have to go in with concrete goals for what you were trying to work on, especially in those patients where there's like a solid list of like 7 things you need to see them do so you can see if they've emerged to a minimally conscious state. That might be a patient where you really are working together to be like, okay, what's our goal here? But a lot of times when I'm working with someone that is, orientation, right? Their memory, they cannot remember where they are no matter what I do, how many signs I put in their room, how many memory books I give them, how many times I repeat the name. And I'm like, gosh darn it, Caitlin has that song that we sing with our patients. And I'm like, let's get her in here. Why didn't I think of that first? I still, even though I co-treat, I feel like I co-treat very frequently with NMTs, there will still be times where I catch myself and I'm like, crap, why didn't I think of that day one? So even as someone that is so pro NMT, I still know I have hangups with just not automatically going to that yet. So.
Yeah. And I think like off of that, it's hard because we're a lot smaller of a department than the speech pathology department and also, the other departments. So I think we have to really like scaffold and triage is the word I'm looking for of, the patients that we're treating. And I would agree that like if we had a full robust like 5 therapists at Spalding, every floor would get a therapist and almost every patient would get a consult. I think, we're working on that. But it takes some time and so we have to be a little choosy about who we treat so that we can really kind of show obviously the efficacy of our program. But I love that, Hannah, and I think also too like there is when I think about the consults that come through, what I love about it is that most of the disciplines when I speak to them, they catch me in the hallway, right? Like Hannah stops me and she's like, I need you I need you for this consult. And like, here's like the laundry list of reasons why I need you to go in there. And here's what I need you to work on. Right. And so like what I love about it is like, they're so clear and they understand what we do. And so they're telling us like, go in and do this, like do your orientation song. Makes my job super easy, right? Like I don't have to walk into a room and be like, why did I get this consult, and sit there and try every assessment, right? So I think it's a perk of working on an interdisciplinary team of just really like hearing from them and it shows, I think, a testament to when you're as clear as you can possibly be about what the services you provide, then the other disciplines will jump on board. And Hannah hasn't actually seen our work with DOC, so after she sees that at Spalding Cambridge, maybe she would refer us to those. So
that would.
Yeah, and definitely it's more like, I think my questioning goes beyond the consult, like, because as you said, Hannah, and we all know everyone could benefit from getting NMT or music therapy, but it's more like, so it goes beyond you telling the NMT like, hey, I think it would be great for you to see this patient kind of like on your own and keep working on these goals that I'm also working on. But like, when do you know it's a patient that just needs that extra hour of therapy with NMT on their own, and when do you know it's a patient that would actually benefit from that co-treating?
I feel like usually for me at least, like we'll do a co-treat first, or like Caitlin will say, okay, I'll go in and do like a quick assessment on them the day before we're going to do a co-treat, and then we'll co-treat and then kind of go from there and decide how often do we want to do co-treats. Do we think it's beneficial based on what we saw today for you to go do your own thing and you keep doing speech therapy, and then we'll talk about it and collaborate whenever we feel like we need to change it up. But I feel like in terms of deciding if it's a co-treat versus see this person on their own, my gut is always, well, I also want to see what you're going to do with them, so then I can incorporate that into my sessions. So I like doing a co-treat versus just being like, hey, go see this person, because then I can take what you guys are doing and incorporate it into my session. So there's more opportunities for practice, and there's more carryover and generalization.
Yeah, and I think that also like the other side of that is if Hannah has a lot to do from a swallowing perspective for some patients, it's nice to like go in, do a co-treatment, see what from a language standpoint or cognition standpoint that we could address, and then from there we might like divide up and see that patient so that they can get additional, because often, and Hannah, maybe you can speak to this, just like you guys also covering a lot of ground, and oftentimes swallowing is well, it's obviously super important. So
yeah. Well, I was just thinking about our friend on Friday, how I never got to do.
Yeah.
I was like, I think that's what you're thinking of too.
Yeah.
That's a great point too. Because speech therapy is a pretty wide net, we do have a lot of goals for our patients, especially those that are in acute rehab. They tend to come in as somewhat still medically complex, with swallowing goals, language goals, cog goals, voice goals, motor speech. So it is really nice too, like Caitlin said, if I can say, okay, they have these language goals, I also need to work on cog, their attention is crap, and they're on puree and honey, then yeah, I can spend some time doing meal treats with them, knowing that Caitlin's also in there targeting cog and language when I'm not there. And then again, we email, we see each other in the hallways, collaborate, talk about how it's going, what else we can be doing. So it is nice to have you guys as a resource, so that I know that those goals are still getting targeted outside of my session, just not necessarily with me. And I think PTs and OTs probably feel the same way. Do you guys, actually, I have a question. Do you guys ever, like for PT and OT, is that mostly co-treats, or do you ever do like individual sessions with them?
Yeah, we split it up, right? So like obviously for gait training at Spalding, it's obviously always in co-treatment. But we might say like, oh man, their cognitive level, like they're super impulsive and they get out of their chair, they don't do their steps before they get out of their chair. So we might actually like do some music mnemonics training of the following safety steps before they get out. So we might branch off and do that, versus like OT, we would definitely a lot of times like the fine motor. So like continue to work on fine motor, or like left neglect cog. We can do all of that kind of one-to-one as well. So I do think there's like there's a nice balance between co-treating and collaborating. And then also this is where knowing your value and knowing that like most patients at that level of care can benefit from more therapy, can benefit. I mean, they're in intensive rehab, and even patients outside of the rehab setting, I think, we get stuck in this whole like seeing patients once a week in a private practice. And we kind of say that it's like enough. But it's not enough. When you think about actually relearning a skill, it takes so much time and repetition that you should, if you can only see that person, because of, let's say, financial reasons, they're paying for your services, if they can only afford once a week, you should be supplementing that regularly, right? They should be doing whatever exercises you're doing with them in person. You should be making it accessible for them to do every other day, every day if possible, because that's when you're going to see the most change and the most carryover. So setting your patients up for success. So it's a nice balance to co-treat and then also add more time.
Yes, this is great advice, and I would love to use like the 10 minutes left to address any questions or comments from people. Maybe you've already have a question before coming into the panel, and that wasn't quite addressed, or something just came up as the conversation was going right now. So if you have any questions, you can unmute yourself or also put it in the chat, and I'll read it out loud. Or comments, just also saying just how cool this is. It's also welcome. We're also, oh, here it is. Totally agree, Caitlin. We have given client and recording of the MIT exercises to practice at home. Really helps.
Hi, Susan. Yeah, no, that's great. I think that one in particular, MIT, like as you guys, you might know, like that intervention, the literature is like every day. Delaney, you might know the actual specs, like every day for like twice 2 hours a day. Like it's like
It's
some,
intense.
yeah, it's some absurd amount of. Oh, actually, Deanna, you should know the answer
I was
to
gonna say
this because
Deanna just did her presentation.
yeah.
For like X amount of weeks. Yeah, Deanna, let us know.
Yeah,
I do have that somewhere. I
Yeah.
did. I did. Wait, what was the specific one you wanted?
Yeah, no, MIT. But regardless, the point is that it's some absurd intensity of treatment for to really see like the
Yeah.
carryover. So I think like, it's not however you can build in that structure. And what I'll say off of that too is like I oftentimes will say to the caregiver, okay, we're practicing these phrases. You have to allow the caregiver too. That's a huge part of like, here's what the phrases are, communication with them so that they can use the phrases. And then, like, if you're working on, like, I'm hungry, then what I'll tell the caregiver is like, put their food in front of them and don't give them a fork. Or, like, then walk away. And they're not going to obviously eat with their hands. They're going to say, they're going to try to tell you that they need something. And in that case, like, they have to use their phrase, right? Or like it's almost, I mean, it's a little evil, but like that's fine for you
It's kind of like constraint induced language
Yeah.
therapy at that point. Like
Yeah,
you're
exactly.
taking away the thing that they need, so they have to use their language to ask for it.
Right, exactly. So I think that that's kind of finding ways to really like boost their program and make it real.
Communication partner training, also important for spouses, I have found, for reinforcement and frustration management.
Yeah, definitely.
Yeah, we try to emphasize that a lot on the inpatient side, especially for people going home, and especially for those people that have communication difficulties. When really making sure the family members understand and can cue appropriately and can rephrase and clarify, and because I feel like at least when I'm seeing someone every day for an hour for 4 weeks, I know that person really well and I know their communication style super well. So I can almost interpret what they're going to want or what they're going to try to say to me just because I know them. And that's a benefit of being a family member, is you know your loved one so well, but really making sure that the family member now knows how to communicate with their loved one in a different way. Like that's just been my baseline. I know that they can't, that their yes, no's are inaccurate. But for this spouse, that's going to be new to them. So I have to make sure that they understand that right off the bat and how to figure out what the person needs. Yeah, it's a really important point.
Yeah, I think definitely education and like that communication with the caregiver, it would be just another interesting topic to explore. But I guess like going really quick, what are your approaches for family education as individual clinicians as well? And have you ever thought of doing sort of like an educational co-treatment session for the families? And how's that been?
I think timing wise, it would be difficult to do it at the same time. But I think that it could be beneficial. I mean, we have a structure where the family comes in at least once, maybe twice. It's been tough in COVID, but for an hour for every single discipline. And then I tend to also email families handouts, resources, websites. I might even send them, videos. I try to give weekly updates about what their loved one's doing. So I do try to really prioritize that because I know it can be really isolating for family members when they're not able to observe sessions and see what's going on.
Yeah, and caregivers, I think this is something from a especially when you're working in the like home setting, managing caregiver expectations, and as like music therapists, as Hannah said, even too, she kind of implied like sometimes it's like you are like the last ditch effort to get whatever function we can out of this person, and that happens in the home as well. And so but the caregivers are the people reaching out, not the clinicians, and they might say to you like, they have fully hemiparesis, very little return in their left arm, and they say, can you make his arm work again? And it's really important as a clinician, and I've made this mistake, so don't do the same thing I made the mistake on of really trying to give them false hope, right? It's important to really like put up front like what you can work on, what you can achieve, making your goals smart and measurable, and the right time frame, and not saying, yeah, sure, we'll do it, or even give them kind of a false hope, right? They are supposed to have hope, like they are supposed to maintain hope throughout all of their loved ones' recovery, but you also, as a clinician, have an ethical responsibility to not, give them, kind of false information of what you can achieve. So that's why the assessment and like measuring your goals and being able to report on that is important.
I think it's also important just to know that if you're in the home setting specifically, at least I found this, that it gets to a point where you're not always just there for the patient, but you're doing something for the caregiver as well. Whether that's involving them somehow in the session or somehow in the days that you're not there, teaching them, like finding the best way in the case of language to help them communicate with their whoever it is that they've requested services for. But, for example, I've had a caregiver in Caitlin's example who was so overbearing about progress, and when you let them know that that you're there for them too, it like is a relief and like weight off of their shoulders, where they trust you a little bit more in the care of their loved one.
Yeah, different. Very interesting topic. I hope so. Like that family education, I feel like I personally, it would be a great addition to the music therapy curriculum, because it's just a new set of skills to manage that. And I wonder if Hannah, you got that sort of like on at school, that training, family training.
I feel like there was not necessarily a course that you took, but in your like practicum, like your supervisors would really emphasize the family education piece and talk to you about how to do that. I think that one of my biggest regrets in grad school is we had a counseling seminar, and I didn't take it in order to take an adult like TBI seminar. And I feel like my counseling skills have definitely grown over the years, and I definitely have looked to at least our hospital psychologist and observed him to see how he counsels families. But it's kind of embedded in the practicums that you do. The ones that are, I feel like, at least with the adult population, I feel like the pediatric population, besides like the deaf and hard of hearing program that we had at my school and our autism clinic, the emphasis on education was definitely emphasized. The school placement, not so much, besides like going to an IEP meeting once or twice. But I feel like it is definitely something that I think schools should probably look at doing more of and making it a requirement, because it ends up being such a huge part of what you do, is explaining what this looks like and what it's going to look like in the future. And just because you have the theoretical knowledge and I understand the neuroanatomy, that doesn't always mean that I know how to explain that to someone that has no idea about any of this.
Mm-hmm.
So,
Yeah.
Emily, you have a question?
Yeah, sorry about that. I had a question for Hannah, actually. Because assessment is so heavily based on the therapist's judgment, how often do you find yourself turning to NMTs for their own co-treatment or their own advice? Because I think collaboration is like a big portion, obviously, of figuring out what the client needs, but I didn't know how often you do that in your practice.
I feel like I do it pretty frequently with my language clients. I think cognition is something that's a little more straightforward in terms of figuring out the actual pieces of cognition that are impaired, but with language, because it can be so confounded by an apraxia, another motor speech disorder. I often will bring Caitlin or anybody in the NMT field who was at the hospital that day into the session to be like, what do you see? Because especially for things that overlap so much, it is very hard to tease out. We even had a presentation the other day in our department, and it was about apraxia. And basically at the end, it was like, these things overlap and it's very hard to tease them out. I was like, yeah, so what do we do about that? It seems like nobody still knows how to really tease apart aphasia and apraxia and other motor speech disorders. So I think that the more eyes and ears you have on a patient or a client, the more like evidence-based opinions you can have. And so I think that mostly in those cases would be the times that I'm seeking out NMTs or other speech therapists even too, to be like, hey, can you come with me into this session? I'm not really sure what this is and it's kind of funky. I think I tend to also be someone that's very open to other people's ideas and opinions. And I really, really love collaborating because I think that it can only make things better. I've never collaborated and been like, well, that made it worse. So I feel like you do, once you kind of open your mind up to it, it's like, oh yeah, now I know so much more than I did going into it. So I'd say a lot.
Yeah, and I do want to be mindful of the time. We are 2 minutes past, so I do want to any last comments or questions. If not, I just want to thank all of you for coming, and thank you, Caitlin and Hannah and Delaney, for just sharing so much information that I think these are just questions that we don't get addressed at class, I think, but they're just sort of like at the back of the mind of people. And I love that we had the opportunity to address them in this medium. So thank you so much. And if anyone has any questions, feel free to email NER-AMTAS, and I can forward the information to the panelists if that's the case. And if not, you have any other specific questions, NER-AMTAS@gmail.com would be the go-to. And aside from that would be it. That's the wrap up of the panel. So thank you so much everyone for coming, and I hope you all have a great rest of your weekend and get to enjoy maybe the weather or the sun, depending on where you're at. Yeah, so thank you so much. Have a great rest of your weekend.
Bye.
Bye. Thank you.